Traditionally, the boot camp has been an opportunity to gain hands-on skills-based experience with some clinical anatomy thrown in. As such, I'd like to make this as interactive as possible. So if you have any questions as we go along, please don't hesitate to enter them using the Q&A function in Zoom. We'll stop periodically so Michael and Graham can read the questions, and we can go back as necessary. We can also field some audio questions at the end using the raised hands feature. So my goal today is to increase your familiarity and comfort with the cerebrovascular system. We're going to take a virtual journey through the major vessels and see what we encounter along their respective courses. As those who have taken any of my courses know well, this is an image I personally despise, and an image I'm sure most of you are very familiar with. While this is a convenient tool for rote learning, it doesn't convey much useful information, most simply because anatomy is not 2D. Some resources make an attempt, and while this is a slightly better representation, it's not a perspective aside from CTs that you will ever use clinically. And understanding the substantial topography of the circle of Willis, which I call the stairwell of Willis, from a 2D representation is nearly impossible. And I think it puts an undue burden onto you as learners. Even this is not a complete representation of cranial circulation, although it's certainly better. So in order to understand cranial circulation in context, and how that vasculature interacts with its surrounding structures, we need to put all of the various pieces together. Many years ago, as an attempt to, I think, unnecessarily simplify neuroanatomy, the subject was broken up into different systems, which are still taught independently from each other. No other area of the body or an anatomy is taught this way. So when I ask students, for example, what vein does the trigeminal nerve pass under after it originates from the pons, or the relationship between the ICA and cranial nerve 7 and 8, I often get blank stares. And this is where I believe that undue burden comes into play, as I think it's unfair to ask you to mentally merge all of these different components on their own when you are rarely taught how they interact. Nowhere do these components exist naturally individually. They are all part of a complete intertwined system. So learning them individually forces you to essentially study the same region multiple times piecemeal. So today we're going to look at how these systems come together and hopefully give you a more complete understanding of the anatomy as a whole, because using this image to understand this and this is nearly impossible. So I'm going to ask you to approach this with me as a virtual road trip, where we shrink our perspective down significantly in order to travel along the vasculature and really see what we encounter along the way. And you put yourself in the perspective of say like a red blood cell traveling along, and as we look around at different points and we see what's around us, and we understand from the perspective of the vessel what else it's encountering. So before we shrink ourselves down, let's just take some time to review the basic bony anatomy that we're going to encounter. So this is obviously the base of the skull, something I hope most of you are familiar with. Today, we will be mostly traveling within the middle cranial fossa and the posterior cranial fossa. So zooming in, this is a top-down view of the midline skull base. So the top of our image here is going to be anterior. The bottom is inferior and posterior, and the sides are lateral. Excuse me. Let's take a look at some of the key bony landmarks we're going to use, beginning anteriorly and moving posteriorly and inferiorly, so down and back. So first, we find our optic canals, which is where we, of course, find the optic nerve and the ophthalmic artery as they exit the skull and enter the orbit. Remember that cranial nerves are numbered from superior to inferior. So we're going to start with 2, work our way 3, 4, and down. Just posterolateral to the optic canal, we find the anterior clinoid process, which is a projection coming off the lesser wing of the sphenoid bone. And this will come into play when we travel along the carotid shortly. Just underneath and anterior to the anterior clinoid, we find the superior orbital fissure, which is a very busy thoroughfare where we're going to find cranial nerves 3, 4, V1, and 6 all exiting the skull going into the orbit. And on the middle fossa floor, we of course have the foramen rotundum, where we find the maxillary nerve V2 exiting, and the foramen ovale, where we find the mandibular nerve, as well as the lesser petrosal nerve, and the foramen spinosum, where we find the very important middle meningeal artery. As we come back a little bit posteromedial, we also have the foramen lacerum, where we find only small arteries and veins passing through, but we find the carotid passing on top. So this is important again when we talk about the carotid. And just supramedial to that, we find the posterior clinoid process. So here's our anterior clinoid process coming off the lesser wing, and we have the posterior clinoid process, which is a projection off of the clivus. And the clivus is the central bone of the skull base, and it connects via the petroclival fissure here, which runs down to the jugular foramen, to the petrous portion of the temporal bone, which of course contains the internal auditory canals, where we find cranial nerves 7 and 8, as well as the labyrinthian artery. I'm listing these simply as a review, as we're going to see most of these structures later in depth as we go through. Below that, we have the jugular foramen, where we of course find cranial nerves 9, 10, and 11, as well as the inferior petrosal sinus and the jugular bulb. And below that, we have the hypoglossal canal, where we find the hypoglossal nerve. And last but not least, the largest and most highly trafficked, this is of course the foramen magnum, through which we find the medulla, the accessory nerve, the vertebral artery, and the anterior and posterior spinal arteries. So this is a portion of our map, and it's a gross depiction of part of the route we're going to take. Now, the bone and brain have clearly been removed here, but let's just from this position descend down a little bit. So we're just moving our perspective slightly inferior. And now we can add the bone back in. Okay, so here we are. This is the posterior fossa over here. And here we have the middle fossa and the anterior fossa over here. We're looking into the middle fossa here. So do you think this is a left or a right side? What do you think? Yeah, so most of you are right. This is indeed a right side. So this is an anterolateral view of midline right side skull base. So this is the right middle fossa. So this is an extradural perspective of the right middle fossa. This is actually an intradural perspective of the posterior fossa, because you can see the dura here has been left intact, where the dura here has been removed. This is the white covering. So all of that is intact. You can see it was cut right along the midline, right here in the anterior skull base. So before we move on, let's orient ourselves with this image. So this direction here is anterior. So this is going towards the nose. This is posterior, going towards the back of the head, the occiput. This is our midline. So right in the midline here, we have the pituitary gland. So this is true midline skull base. And as we move in this direction, we're moving lateral towards the ear. Up here, this is superior, and down in this direction would be inferior, and then this would be lateral on the left side. So this is all the right side, this is the left side, mostly intradural here. The dura has been removed, so we're extradural and anterior. And we're looking slightly down onto the right side of the middle fossa floor. Now let's look at that in relation to the bone that we just looked at a few minutes ago. So don't be confused by all of the additional structures that were added in. It's the same bony anatomy that you're very familiar with. And so again, we have the nose, the vertex, the ear, and the occiput. And so let's identify these surroundings quickly before we journey through the vasculature so we can correlate what we see later on. So this is a very important bony structure we saw on the dry skull. This is the anterior clinoid process, and the carotid here is coming up just underneath the clinoid. So this becomes very important for accessing the clinoid surgically. We also have the optic nerve running right here. So there's our anterior clinoid processes. This is the anterior surface of the petrous portion of the temporal bone. The petrous apex is highlighted in yellow. Now, let's move forward by peeling away the epinerium that's covering the nerves here. So now that we have everything clearly exposed, on the very bottom, we can see the foramen spinosum the middle meningeal artery coming through the foramen spinosum, cut right here. And here we can see where the foramen spinosum is on the dry skull. And moving a little more medially, we find the foramen ovale. And of course, through the foramen ovale, we have the V3, or the mandibular, the V3 branch of the trigeminal nerve. Moving more medially, we have the foramen rotundum and the V2, the maxillary nerve. And of course, the superior orbital fissure, where we find V1, the ophthalmic nerve. As well as the trochlear nerve, cranial nerve 4 here in yellow, which originates on the posterior surface, the back of the brainstem, and it turns anteriorly, and it courses laterally around the brainstem. So it has a really long course. It originates all the way in the back, goes around the sides of the brainstem, and then joins and runs with the tentorium, and is pretty parallel to the free edge of the tentorium, which we see here in the green arrows. And the fourth nerve comes in with the free edge of the tentorium, goes into the cavernous sinus, and exits through the superior orbital fissure. So we have third nerve. Third nerve has a much more short and direct course. It comes slightly down. It has a little bit of a superior origin that goes directly down, and it comes on top of the posterior clinoid process right here. So this is the clivus, right? And this is the posterior clinoid process. This is the free edge of the tentorium passing laterally to the posterior clinoid. And just above it, we have third nerve coming down from its origin and going through the ocular motor triangle, exiting the dura, entering the cavernous sinus on its way to the superior orbital fissure. And down here, deep under here, we have the sixth nerve, the abducens nerve. The sixth nerve has a short, direct, and slightly upward intradural trajectory. It exits the dura right here through this opening called Dorello's canal, enters the cavernous sinus, and travels underneath V1 on top of the carotid on its way to the superior orbital fissure. As it travels through Dorello's canal, it passes underneath the petrosphenoidal ligament, otherwise known as Gruber's ligament, which forms the roof of Dorello's canal. Another important structure we find in the middle fossa is the greater superficial petrosal nerve, which emerges in the middle fossa as it comes out of this opening here called the facial hiatus. And it courses directly medially underneath V3 before it enters the Vidian canal deep. And this is also very important because we'll see why shortly that this is a great superficial landmark for the petrous portion of the internal carotid artery. So let's go through this anatomy, everything we see here. All the way up here, we can see intradurally first nerve as it exits the dura and it's going anteriorly, and then it'll innervate down through the cribriform plate. Second nerve runs on top of the carotid here, entering the optic canal and going into the orbit, right just medial to the anterior clinoid process. Then we have third nerve from its more superior origin. It has a slightly inferior direct course, goes on top of the posterior clinoid process, goes through the ocular motor triangle, exiting the dura, entering the cavernous sinus, on its way to the superior orbital fissure. Then we have fourth nerve. Remember, we're numbering down. So 1, 2, 3, 4. We have fourth nerve originating all the way posteriorly on the posterior margin of the brainstem, coming around laterally the brainstem, coming anteriorly, running with the fridge, the tentorium. The tentorium is cut here. This is a cut. And it's coming in, it's coming with the free edge of the tentorium, it's exiting the dura, entering the cavernous sinus, on its way to the superior orbital fissure. Then we have fifth nerve. Fifth nerve has a course that's pretty straight, except as it comes up from the brainstem, it kinks up ever so slightly to go on top of the petrous ridge right here. So it kinks up and it exits the dura by going into Meckel's cave. Enters Meckel's cave, comes out in the middle fossa, so up and over the petrous ridge, into Meckel's cave, into the middle fossa, and trifurcating into V1, going to the SOF through the cavernous sinus, V2 going through the cavernous sinus to foramen rotundum, and V3, which is extra cavernous and going to foramen ovale, going on top of the GSPN, which is running underneath on its way to the Vidian canal. Down here, which we don't see in this picture, we also have sixth nerve. Sixth nerve is going straight into Dorello's canal, going underneath V1 on top of the carotid, the cavernous carotid, which is hidden all the way down here, and running pretty straight all the way underneath V1, all the way to the SOF, where it exits and enters the orbit. So given what we just said about the right side over here, what let's see, can you name the structure in yellow? Take a close look at it. About 30% have said it's contralateral abducens. 18% say it's contralateral. Third nerve. This is actually still the abducens nerve, but this is the contralateral sixth nerve. And the reason we can say that, there are a few reasons. One is this is our clivus, right? So this is the long axis of the clivus, the anterior or the superior to inferior, the caudal or the cranial and caudal direction. Cranial up here, so it's coming down the slope. And we know the third nerve passes on top of the posterior clinoid, which is projecting off the superior end of the clivus. So if we follow that around to the other side, this is the opposite side, almost. It goes a little bit further. Sorry, my mouse wasn't on. Where you can see this is the posterior clinoid here, and the opposite one would be about here. This is the midline where we find the pituitary. So this is too low to be third nerve. And it's just about medial enough to be sixth nerve. And we know that because we generally find sixth nerve at the angle between the clivus and the petrous ridge. And that's usually where you find Dorello's canal. So the last thing here, you might know what this is. This may not look familiar, but it should be something you know very well. And this is what we collectively know as the cavernous sinus. You're probably used to seeing the cavernous sinus as this really boring 2D image. But a very easy way to remember it is Odom the cat. Ocular motor, trochlear, ophthalmic, maxillary, carotid, abducens. From medial to lateral, from superior to inferior. And we can translate that roughly to what we see in a real specimen. So this is a top-down view of the cavernous sinus. The top of the image is anterior, and the right side is lateral. So this is the right middle fossa, and this is all dura. So this is an intradural perspective at the moment looking out. So now imagine we're hovering here in a helicopter, and we're just going to keep that perspective, but we're going to descend down a little bit. So now we're hovering in the posterior fossa, looking anteriorly. On the left, we are intradural, and on the right, we're extradural. So the white is the dura, it's been removed on the right. So now we can go through that same anatomy from this perspective. So we have second nerve here going into the optic canal on top of the carotid. It's coming from here where the optic chiasm would be, which is in the midline, just above the pituitary. Here's its stalk. Here's third nerve. And third nerve, as you can see, is going right over, up and over the posterior clinoid process. And we can see on the left side that it's exiting the ocular motor, or entering the ocular motor triangle, exiting the dura, entering the cavernous sinus. On the same side, we can see fourth nerve as it's running with the free edge of the tentorium here. The tentorium right here has been cut, but you can see this was the direction 4 was coming in. So 4 is coming in, exiting the dura, entering the cavernous sinus on its way to the superior orbital fissure. As we move down, here's 5. And this is the dural entrance into Meckel's cave. So 5 is coming from about here, very short intradural course, coming up and over the petrous ridge, entering Meckel's cave, and then you can see it's fanning out on the floor of the middle fossa here. So here's our cavernous sinus down to V2. So V3 going to foramen ovale, V2 to rotundum, and V1 to the superior orbital fissure. And we can see just underneath it, here we have sixth nerve. And sixth nerve is pretty inferior to 5. It's much easier to see in 3D. It's pretty inferior and medial to 5. So 1, 2, 3, 1's over here. 1, 2, 3, 4, 5, 6. And 6 is coming up a little bit, going into Dorello's canal, which is covered by Gruber's ligament, entering the cavernous sinus, underneath V1, on its way to the superior orbital fissure. And we have V1, 6, 4, and 3 all interacting with the carotid and the cavernous sinus right here. So before we move on, are there any questions? All right, to begin very briefly, the common carotid originates on the left from the aortic arch, and on the right from the brachiocephalic artery, which comes off of the aortic arch. So as the common carotid comes up the neck, it bifurcates at the green arrows and forming the internal and external carotids. So for our journey along the internal carotid, we'll be navigating using what's known as the Boutier or the Van Loveren classification, which is numbered from proximal to distal following blood flow. So now we'll shrink ourselves down and take on the perspective of the carotid as if we were a red blood cell going through. And we begin in the first segment, which starts at a fork in the road. So we're coming up, and if you close your eyes, you're coming up and you see a fork. And we can either go to the more medial or to the more lateral. This travels up the neck, so hence the C1 is the cervical segment. And it begins at the bifurcation and goes all the way up to the entrance into the carotid canal. So the first segment of the ICA is the C1 cervical segment, which is long. Travels straight up from the bifurcation until the entrance into the carotid canal. So when you come to that fork in the road, you can either go to the internal or the external carotid. So we're going to go obviously into the internal carotid. And as we enter the tunnel of the carotid canal, we also enter the petrous bone. And this is unsurprisingly the C2 or the petrous segment of the ICA. And for a moment, we continue to travel upward before we encounter the first genu, the first major bend of the carotid. As we come up and approach the petrous apex, we take a very sharp, almost 90-degree turn anteromedially, all within the petrous bone. So this is, as we come up right here, this is that first bend, and everything is covered by bone here. We're passing a lot of important structures of the middle ear and the internal auditory canal. So we're coming up and we're having that first big bend. And as we do, we're coming back to a view that we now know. The bone is removed. And we can see the carotid right here as it emerges from this first bend underneath the GSPN that we saw before. So this is the same view we have up here, just using the dry skull. So that's our first bend. We come up and over the bend. As we look up, we would see normally bone, but since the bone's been removed, here we look up and we see the GSPN running on top of us. So we know we're running in a lateral to medial direction, ever so slightly anteriorly. So now here, the carotid is, as it would normally be, covered by bone. So if you can imagine, you're sitting here, and you look up, and you see a very thin layer of bone with a very straight and parallel nerve on top of it. And this is our GSPN as it's going from laterally to medially on its way to go underneath B3. So the C2 petrous segment continues medially, ever so slightly anteriorly within the petrous bone until going underneath V3 and the trigeminal ganglion, all the way until it reaches the posterior margin of the foramen lacerum. So again, we have C1 from the bifurcation, C1 cervical segment from the bifurcation, all the way up to the entrance into the carotid canal. Then we begin our C2 segment, which begins entering the canal. So we're inside this tunnel of bone. We're going up, up, and then we finally emerge. We turn, and we flatten out, return, up and over, and we're now running medially in the petrous bone. So we go from the C2 cervical, from the entrance into the carotid canal, to the posterior margin of the foramen lacerum. And during this course, the C2 segment gives off two branches. The first is the caroticotympanic artery to the middle ear, and the other is the Vidian artery, which is going to go in the Vidian canal, which would be here. Here is the petrous segment zoomed in with the trigeminal removed. So here we can see, to orient ourselves, we have cranial nerve 3. So again, this is the oculomotor nerve, and this is where the oculomotor triangle would be. And it enters the cavernous sinus, exiting the dura, on its way to the supraorbital fissure, which would be here. This is fourth nerve. right here coming in, exiting the dura, entering the cavernous sinus on its way to the superior orbital fissure. This is a cut V1 right here. Underneath it, we can see sixth nerve. So here's sixth nerve coming up, entering Dorello's canal, going underneath Gruber's ligament. This is where the clivus and the petrous bone meet, right here. So this is where sixth nerve comes in, going on top of the carotid, underneath V1, on its course to the superior orbital fissure. This is V2 cut and V3 cut as well. And as we said earlier, the ICA doesn't pass through the foramen lacrum, but rather on top of it. So thus, we have the C3, or the lacrum segment, which begins at the posterior margin of the foramen lacrum, and which is roughly beneath V1, or the area between V1 and V2, underneath the trigeminal ganglion. Actually, let's take a moment here. We can see here's fifth nerve from its origin, coming up, going up and over the petrous ridge has been drilled here. So this is the intradural course of 5, going up over that petrous ridge and fanning out so beautifully in the middle fossa, V1, V2, and V3, all of this being the cavernous sinus. Here we have fourth nerve coming all the way around the brain stem from its posterior origin, coming in with that free edge of the tentorium, entering the cavernous sinus. Here's that third nerve course. Again, a little superior origin, coming at a slight angle downwards into the oculomotor triangle, exiting the dura into the cavernous sinus, and all of them going to the superior orbital fissure. You can't really see 6 here. You can see contralateral 3, though, quite nicely. And this is where the posterior clinoid would be. This is the clivus right here, and that's the long axis of the clivus, where we're later going to see the basilar artery. Up here, we have first nerve and second nerve, and the pituitary in the midline. This is our orbit. Everything here, the extraocular muscles, you can see the globe right here. Also, we have the middle meningeal artery coming out of the foramen spinosum right here. Here's 7 and 8 going into the internal auditory canal, and the seventh nerve is coming into the geniculate ganglion, and it's giving off the GSPN that we looked at before. And the GSPN is exiting through the facial hiatus, running very superficially on top of the petrous carotid here. So when you're surgically trying to identify the location of the petrous carotid, the GSPN is really invaluable because it's really perfectly superficial and parallel to. So if you're doing an anterior transpetrosal approach where you're removing a portion of the petrous ridge right here, it's very useful to know how to avoid the carotid. So this is a nice approximation of where the foramen lacrum is, right about V1, V2. And so this is where the carotid has its next major bend. So we had the first major bend as we came up to the into the petrous bone, and we turned medially, and then we ran straight through the petrous bone medially towards the midline, going from the petrous segment to the lacrum segment on top of the foramen lacrum, and now we're going to turn upwards again. We're going to have another one of those really sharp 90-degree angle upward bends as we come in, and as we turn superiorly, I should say. So we're going anteromedial, and then now we're curving superiorly. And as we curve superiorly, we encounter this structure in yellow here. Does anyone know what this structure is? I see there are some questions that came in. I'll answer quickly. The ligament, well, I'll answer after this one, is the GSPN the same nerve as the pterygoid canal? Yeah, so the GSPN, there are 3 different nerves here. There's the deep petrosal, the lesser petrosal. GSPN comes in, joins with the other, and becomes the nerve of the pterygoid canal, the Vidian nerve. Okay, so the guess here, 32% said this is the petrosphenoidal ligament, and 26% said this is the anterior petroclinoid ligament. No, actually, this is the petrolingual ligament. And you don't really see this much surgically because it's really deep in here. And you really have to remove well, in theory, would have to remove the trigeminal to see it. But it has a really nice function because it really holds the carotid inside the region here. It pins the carotid to the bone. So the carotid isn't twisting around and tearing when you're turning your head left to right. So this extends from the petrous apex over here to the lingula of the sphenoid bone. And this is important, not just from an evolutionary standpoint, but because here it denotes where the carotid enters the cavernous sinus. So before this, the carotid is extracavernous. In here, the carotid enters the cavernous sinus. So again, we have the C1 cervical segment from the carotid bifurcation all the way to the entrance into the carotid canal, straight, no branches. Then we have the C2 or the petrous segment from the carotid canal up, curving medially inside the petrous bone all the way to the posterior margin of the foramen lacerum. And the C2 segment gives off the caroticotympanic and the Vidian arteries. And then we have the lacerum segment from the posterior margin of foramen lacerum bending upwards superiorly until we go underneath the petrolingual ligament and enter the cavernous sinus. And the C3 lacerum segment does not give off any branches. So now we have the C4, or the cavernous segment, which begins at the petrolingual ligament and continues up, traveling underneath the abducens nerve, which we saw before. Here's our sixth nerve. We can see right here as well, Dorello's canal, Gruber's or the petrosphenoidal ligament up here, petrosphenoidal ligament, petrolingual ligament, and going underneath V1. So as the carotid comes up, as we're going through the carotid, and we come underneath this petrolingual ligament, this sort of archway, we look up and we're going underneath this small two-layered thoroughfare. We have one overpass here with sixth nerve, and on top of that is a little bit larger of an overpass with sixth nerve. As we continue up, we're also going to encounter the much smaller fourth nerve, and then also the pretty large third nerve. So the cavernous ICA then bends inferiorly this time, and it kinks out ever so slightly laterally. So it's going up and then down and then slightly kinking out laterally. And then turning again and going upward until we get to the proximal dural ring. So C4 petrolingual ligament all the way up and then down, slightly lateral, then going back up again. It's almost like an S shape. It's not this perfect in every person, but you usually find at least 1.5 major bends, maybe not so acute. So we find the proximal, all the way to the proximal dural ring here, which is found just underneath where the anterior clinoid process would be, the so-called clinoid space. And this is where the anterior clinoid process would project. So if you drill it out and you remove it, you have created the clinoid space, which is important if you want to access these structures to cut them and mobilize the carotid laterally. And we'll see why in a minute. Over the course of the cavernous sinus, the internal of the cavernous segment here gives off 3 main branches. The first is the meningeal hypophyseal trunk over here, then the inferolateral trunk down here, and also some McConnell's capsular arteries on the medial aspect. The meningeal hypophyseal trunk, the MHT, arises from the posterior aspect of that first downward bend. So we're coming up and then down. And this is the MHT right here. So you can see it's the posterior surface right here, and it's projecting posteromedially. And as we can also see, if we keep looking, so that we have that first bend, and now we're coming down, and you can see how the carotid kinks out ever so laterally, ever so slightly laterally, before it turns back up and comes to the proximal dural ring right here. Proximal dural ring is also a nice feature to keep that carotid tethered to the bone. So just looking quickly at the anatomy again here, here's the clivus, right? Here's where the posterior clinoid is on the edge. This is third nerve, so we've come over the posterior clinoid, going down, entering the oculomotor triangle, exiting the dura, entering the cavernous sinus, the SOF. Second nerve, as it enters the optic canal, you can see this ridge of dura. Here's the falciform ligament. Here we have fourth nerve running with that free edge of the tentorium. Free edge is, or the tentorium itself is cut more posteriorly here, so you can really appreciate the relationship between fourth nerve and the tentorium as it exits the dura, entering the cavernous sinus, also going to the superorbital fissure. Down here, we have fifth nerve, exiting the dura, entering Meckel's cave, going out into the middle fossa again and fanning out. And here's sixth nerve right here, and you can see as it goes into Durell's canal, again covered by Gruber's ligament, going underneath V1 on its way to the superior orbital fissure. So here we have the meningeal hypophyseal trunk. And this trunk consists of 3 to 4 main branches. The first is the inferior hypophyseal artery. So I like to imagine this as we're coming down, or coming up the C4 highway here. This is our first exit ramp. And this can take us to several small towns along the way. So the first one is the inferior hypophyseal artery, and that goes to the pituitary gland. Then we have the artery of Bernasconi and Casanari, which is the tentorial artery, going towards the tentorium, which has been removed here, so we don't really see it. And then we have the dorsal meningeal artery, the dura of the upper clivus, going towards the dura of the upper clivus, as well as some small clival branches scattered throughout. You can really appreciate this branch nicely here. Okay, so just for fun, let's answer a neurosurgery board review question about the MHT. So what is the most constant branch of the MHT? The overwhelming response seems to be the inferior hypophyseal artery. I believe the most constant branch is the artery of Bernasconi and Casanari, or the tentorial artery. But maybe the literature has changed since the last board review book was published. But as far as I know, it's the Italian artery. The artery of Bernasconi and Casanari is the most constant branch. What does most constant mean? It means that what you find most commonly on angio. So what is the most consistently found branch? Okay, so now as we continue down towards the second genu, we find the infralateral trunk. And we find that here because it is both inferior and lateral. So all the way up here, we have the meningeal hypophyseal trunk, but as we come down, we have coming off the inferior and lateral surface of the vessel as well, the infralateral trunk, which gives 3 to 4 small branches that supply the nearby cranial nerves. Here we see a branch going to V1, not the most common, but it's quite clear. So from here, the ICA comes up and passes through the proximal dural ring. And it's exiting the cavernous sinus and becoming both extra cavernous and extradural. So we have C1 from the bifurcation to the carotid canal, C2 from the carotid canal to the posterior margin of foramen lacerum, giving off the caroticotympanic and Vidian arteries. We have C3 from the foramen lacerum to the petrolingual ligament, giving off no branches. And we have C4 from the petrolingual ligament coming up, giving off the MHT up here, coming down, giving off the infralateral trunk down here, coming up, and going through, or ending at the proximal dural ring, and then the carotid's passing through the proximal dural ring, and it's exiting the cavernous sinus right here. So this proximal dural ring, together with all the meningeal architecture in this area, is really sealing that cavernous sinus off together. So now as we're exiting the cavernous sinus, we're becoming both extracavernous and extradural, and we enter the C5, or the clinoid segment. And of course, this is named the clinoid segment because we're now in the clinoid space where the anterior clinoid would normally cover. And this is a very small but very important segment of the carotid, and it extends from the proximal dural ring until the distal dural ring, which are both underneath the anterior clinoid process. And so what it means by being both extracavernous and extradural is that if you had a bleed here, it would not be a subarachnoid hemorrhage. So, and this segment ends at the distal dural ring, where the carotid does in fact enter the dura. So it differentiates the type of bleed as well. So here's our distal dural ring, and this is where the carotid now enters the dura and goes into the dura properly and becomes intradural. So let's take a closer look at this C5 region before we move intradural, excuse me. Okay. So again, here's where the foramen lacerum would be. This is the internal opening of the carotid canal, foramen lacerum. And this is the clivus. This is a right side ICA. Here's the anterior clinoid process. This is the sella, so this is where the pituitary would be. This is where the posterior clinoid process would be up here. So carotid's coming in, it's coming, this is where the petrolingual ligament would be right here. Actually, in some people, it's completely ossified, so it's solid bone. And as you come up, we have that first bend coming superiorly, coming up. We have our exit road, or the meningeal hypophyseal trunk. That's our first possible exit. Then we're going to come back down the slope, and we can exit if we wanted to go to the cranial nerves or exit the skull right here. A very easy way would be hop on the infralateral trunk, and it could take us out to the cranial nerves and to the foramen that are right there. If not, we come back up and we go underneath the anterior clinoid process, and we exit the cavernous sinus, and we go in between the proximal and distal dural rings. So if we look at this really nice illustration on the right, there's so much information you can glean from this. And we can see down here, this is the proximal dural ring. So you can see how this seals off the cavernous sinus. These lines here are supposed to represent the venous plexus of the cavernous sinus. And on the right, these would be the nerves here. So 3, 4, and V1. And this is the anterior clinoid process. So as we come up, we're exiting that cavernous sinus, and we're now extradural, extracavernous. As we enter the distal dural ring here, we enter the dura and become intradural. And both the proximal dura and the distal and proximal dural rings meet and connect posteriorly. And in many texts, you'll find this is referred to as the carotid collar. And it's not as confusing as many books and publications make it out to be. It's technically challenging to deal with, but the anatomy here really isn't so complicated. And these rings join in the back, so you have and you can open them up if you wanted to access this region. And the reason you would do so is because this is not an uncommon site for aneurysms. This is the carotid cave, the medial aspect of the carotid. So you can get a carotid cave aneurysm here. So you have to come in, shave down the anterior clinoid process, cut the distal dural ring, mobilize the carotid laterally, and you can expose the carotid cave. So before we move intradurally, until this point again, we have C1 cervical segment, we have the fork in the road we come to, we hop on the internal carotid artery highway. So we go from the C1 bifurcation all the way into our entrance into the carotid canal. We enter the carotid canal, we go into our tunnel, we have the petrous segment, and we go in all the way straight up and we curve over. If we wanted to go to the middle ear, we can get on the carotidotympanic artery. If we wanted to go into the Vidian canal, we can hop on the Vidian artery. If not, we stay straight anteromedially. We emerge from the carotid canal underneath the trigeminal nerve, and on top of the foramen lacerum. We're in the lacerum segment now, which extends all the way up to the petrolingual ligament, which we'll find right here. So we want to go to the cavernous sinus. We take the bend of this road superiorly all the way up. We're intracavernous. We look up. We can see sixth nerve. On top of sixth nerve, we know there's V1 because those two run one on top of the other. And here's sixth nerve separated to show. As we go further, we're going to encounter fourth nerve on top of us. Then we can exit by the meningo-hypophyseal trunk if we're going to one of these small places around here. If not, we keep going, we come down. There's third nerve on top of us. Third nerve and fourth nerve can cross the carotid, 2 to 3 times in this region. And as we come down, if we wanted to exit and go to any of these little vascular outposts here to the cranial nerves exiting, we can hop on the infralateral trunk. If not, we stay on the carotid. So C4, petrolingual ligament, all the way to the proximal dural ring. And then we're underneath the anterior clinoid process. And we come up just medial to the anterior clinoid process, and then we're between the proximal and distal dural rings and the clinoid C5 segment. And then we can, if we wanted to go intradural, we can go through that distal dural ring. So before we move intradural, are there any questions? I'll give you a minute because I saw someone posted last time after I asked. Someone said, could you point that out again? I don't know what that refers to. The petro. Okay, so yeah, so the can you demonstrate the petrosphenoidal and petrolingual ligaments, I think? So this is the petrosphenoidal ligament, the Gruber's ligament. And it goes from the clivus, the petrous apex. It runs almost medial to lateral. And if you imagine, let me see if this other previous image shows it better. Yeah, so the clivus comes down and at some point it joins the petrous ridge, and that forms an angle. And so the Gruber's ligament just covers that little angle between the clivus and the petrous ridge, and that within that angle is Dorello's canal, and that's where we find sixth nerve, and it's about at the level of the petrous ridge. About Dorello, which is the complete one, which is not? Can you explain? I don't know fully what you mean by complete. They're both wrapped completely around the carotid, and they meet posteriorly, and both the proximal and dural rings connect posteriorly. Which cranial nerves actually go through the cavernous sinus versus going along the dura of the cavernous sinus? That's actually a fairly loaded question. Because if you ask a histopathologist versus a neurosurgeon, you'll probably get 2 different answers. The way it's traditionally taught is that V2 all the way up to third nerve or run through the dura of the cavernous sinus, which makes up the lateral wall of the cavernous sinus. We're actually putting a big paper out about this next week. So you'll find in the dura propria of the cavernous sinus, you'll find 3, 4, V1, and deep to that, you'll find 6. Let's see. Do you find much anatomical variation in the main structures? Not a ton. You will see some variation in the curvature of the carotid here, also the angle of the carotid. We just published a paper looking at what happens if the carotid is low coursing and you have an aneurysm here and it shortens this opening. So you have to figure out how to deal with that. But in general, you don't find a ton of variation. 3 and 4 almost always run together and on their way to the SOF. And given the large bone openings of the SOF, the foramen rotundum and the foramen ovale, it's pretty consistent. The most, in general, cranially, the most anatomically variant structures are veins. Let's see, what else do we have? What other indications for creating the clinoid space and mobilizing the carotid ladder? I don't want to get too much into the specifics of, I'll start my video. I don't want to get too much into the specifics of indications for skull-based surgery, but there are a number of reasons why you might drill the clinoid, not just mobilizing the carotid. In some cases, you have to open up the superior orbital fissure to mobilize third or fourth nerve. If you need to get into or through the cavernous sinus, that's another reason. If you need to just make space, there are 2 main surgical windows here. One is the optico-carotid window, meaning you're creating a window between the optic nerve and the internal carotid. The other is the carotid ocular motor window. As you can even see from this image, one is going to be much larger than the other. So just to create that window, you can cut the distal dural ring to mobilize the carotid slightly and open it up. If you were doing a really extensive skull base opening and you wanted to go all the way into the posterior fossa up here, you could mobilize, you could do those things, expand the carotid ocular motor window to get to the the posterior clinoid process. You could drill down the posterior clinoid process all the way here, which gives you access to the basilar tip region, especially if you have a little bit lower riding basilar than in this image. Basilar tip, most basilar tip aneurysms are coiled these days, but not everywhere in the world has endovascular capabilities. So that's one indication. Also, if you wanted to get to the SCA right at its origin, or anything on the upper third, that's a good skull base way to do it, is doing the, oh sorry, my mouse wasn't on. Basilar tip is over here. This is the SCA, PCA, so you could take down some of the posterior clinoid process to get into this region by going through this window here. Easier, it's a neurosurgical clip and aneurysm that is between the distal and proximal dural rings compared to others. Definitely not. Anything more superficial, like a superficial MCA aneurysm, would be much easier. At which point the carotid on its way into the carotid canal and distally pierces the dura. Okay, sure. So again, carotid enters the skull at the carotid canal. Sorry, it enters the skull at the carotid canal. It comes up, and then it emerges. Let me see if we get a better image. And it comes up here. So it's coming this way, right? So this is the midline in this image. So this is lateral. So it's coming up, and you can see the angle here is slightly anterior. That's why I say it courses medially and slightly anterior as it comes up. So it's coming up, and it emerges at the intracranial orifice of the carotid canal. So we start to see it here. And it's coming underneath the trigeminal nerve, and GSPN will be running on top of it. And then it kinks up, and it goes underneath the petrolingual ligament, and that's where it enters the cavernous sinus. So it's intracavernous here, right? So it's extradural, intracavernous, after the petrolingual ligament, intracavernous all the way until the proximal dural ring. Then it becomes extracavernous, extradural, and then it goes to the distal dural ring right here, and it enters the dura, and it becomes truly intradural. That's 2 years previous in school, but the course don't tell us much. In relation to cranial and 4. And okay. You know what? If whoever asked about Parkinson's triangle, ask me again at the very end, and we can pull up some images to look at, because I don't want to get too much into cavernous sinus triangles right now. But 6 nerves would be here, and V1 runs on top of it. So it's over. We can look at that a little more laterally. There are a number of different middle fossa triangles that can be used to work in and around this area. Okay, so let's keep going. But before we jump into the dura, let's just stop for a moment to take a quick look at the middle meningeal artery, as it's clinically important. At the carotid bifurcation, the external carotid comes up parallel to the internal carotid, and it terminates into 2 branches. The first is the superficial temporal artery, which runs laterally up the side of the skull with the temporalis muscle. It's a great target for bypass, as well as the internal maxillary artery, which is running in this direction towards the infratemporal pterygopalatine fossae. And the internal maxillary artery gives off the middle meningeal artery in most cases. And then the MMA then enters the skull through the foramen spinosum. And here we can see, again, from our perspective that we should be comfortable with now, here's the foramen spinosum, here's the middle meningeal artery entering. And the middle meningeal artery tethers the dura of the temporal lobe down to the floor of the middle fossa. So if you wanted to move that dura, you have to, one of the things you have to do is ligate this artery. So it comes up, and again, here's our GSPN going over the carotid. We can see the carotid here as it's coming out of the carotid canal. This has been drilled out, so you can see it. It would naturally come out a little bit more medial, and then the carotid's coming up underneath here, entering the cavernous sinus, and we can see, as a quick mention, this is the distal dural ring. So you can see very clearly how it comes up. This is the proximal dural ring. So right here is C5. So it's extra cavernous, extradural, then it's coming up and in. It's very short. This is the clinoid space where the anterior clinoid would have been. And this is the carotid entering the dura through the distal dural ring right here. And we can see it's going right underneath second nerve as it's going into the optic canal. And then again, third nerve coming off the brainstem, that's its origin. This is its entire intradural course. Don't forget that, well, we would normally down here see the SCA and the PCA, which have been cut. This is the basilar artery. So we have third nerve coming in, going all the way on top of that posterior clinoid process into the oculomotor triangle, down into the cavernous sinus. Fourth nerve would be in here with the free edge of the tentorium, which is also wrapping around the brainstem. So back to the middle meningeal artery, which is clinically important because it is the most common site of epidural hematomas. So very briefly, on the left, we have an axial non-contrast CT that shows a large right biconvex hyperdensity consistent with an epidural hematoma. And as we can see, it's causing mass effect here. And that mass effect is also causing midline shift. And we can see the midline shift because as we can identify the falx right here, we can see it's not in the midline. It's being displaced to the contralateral side. So in general, epidurals look like lemons. They are extradural, and they are emergent in part because they can cause uncal herniation. And I'm sure in your textbooks you've learned a lot about different herniation syndromes in the brain, but it's much easier when you take a look at what that actually means. So where's the uncus? The uncus is the medial part of the temporal lobe. It's the most medial part. And when it comes down, because of swelling or being pushed or mass effect, it comes down and it's pushing on the third nerve. And that is why you see a blown pupil. So it comes down and pushes on the third nerve. And this of itself is not necessarily life-threatening, but what is life-threatening is if untreated, the uncus can also compress the midbrain, causing respiratory arrest and death. So you can see here, this is superior, right? Here's our midbrain going up. There's the medial portion of the temporal lobe. And again, here's the origin of third nerve. going straight on top of the posterior clinoid. This is the fibula of the tentorium wrapping around. So we'd expect to see fourth nerve running with this. And this is coming over the posterior clinoid and exiting the dura. So a couple clinical correlations here. One is uncal herniation. The other is the middle meningeal artery, most common site of epidural hematomas. Okay, so now back to the internal carotid artery. We've gone extradurally from the bifurcation through the petrous bone, through the cavernous sinus, and up to the distal dural ring. Now we pass through the distal dural ring right here, and we enter the dura. And we turn yet again. I just want to make sure we're familiar with this view. This is a top-down view of the midline skull base. So anterior, we are superior looking down. So this is anterior, we're looking inferiorly, and this would be lateral, and this is the midline. So this is the long axis of the clavus. When I say long axis, I mean superior to inferior and slightly anterior to posterior. It comes down towards the foramen magnum down at the bottom. We very clearly see the posterior clinoid process here. This is our pituitary stalk. Here's third nerve coming up. It was, when we saw it in the last image, it was right about here. We saw it coming up. Now it's going straight. Again, oculomotor triangle, cavernous sinus, superior orbital fissure. Second nerve, optic canal. Fourth nerve, we can see here. We don't really see it here very much, but it's coming in, exiting the dura, going into the cavernous sinus on top of the carotid, cavernous carotid, on its way to the superior orbital fissure. We have fifth nerve going up and over that petrous ridge, coming down, fanning out, V1, V2, and V3. Here we can see the GSPN. The middle meningeal artery is right here. And here's our petrous carotid. So our petrous carotid, again, coming through carotid canal, foramen lacerum, up, petrolingual ligament, coursing up, giving off that meningeal hypophyseal trunk, coming down. You can see the kinking laterally very clearly here. It's very noticeable in angio. And then you can see the, here we have the infralateral trunk. And then we come back up. We exit the cavernous sinus via the proximal dural ring. We have our clinoid segment. And then we come up and we can enter the dura through the distal dural ring. So this segment here is the C6 or ophthalmic segment, as it gives off the ophthalmic artery right here. And it extends from the distal dural ring to just proximal to the posterior communicating artery. In addition to the ophthalmic artery right here, the C6 segment gives off the superior hypophyseal artery. And when we saw the inferior hypophyseal artery coming off the meningeal hypophyseal trunk, going inferiorly to the pituitary, and this is the superior hypophyseal coming off the carotid and going superiorly to the superior surface up here of the pituitary. So there's our C6 segment. So just to, you can kind of figure out where we are. This is, we're anteriorly now looking posteriorly. These are the ears on either side. These are the top of the orbit here, the supraorbital, the eyelids. You can see the frontal sinus here. So the brain on the end, the front of the brain here, the frontal lobe has been cut. These are the roof of the orbits here. And this is the left, this is the right and left optic nerves going into the optic canals. So we're just gonna flip this image to take a closer look. Okay, so now on to the last segment of the ICA, the C7 or the communicating segment, which extends from the posterior communicating artery origin to the terminal bifurcation into the anterior and middle cerebral arteries. Let's take a closer look. But before we go, let's just go back and quickly take a look at our real circle of Willis to see what we're looking for. So remember, this is our cavernous segment, right? And as the carotid comes up here, we can see it comes up and it gives off, so we have C6 right here, gives off that posterior communicating artery, which is going all the way to the PCA, the posterior cerebral artery. So it becomes the C7 segment, and then it comes up and it gives off the ACA medially and the MCA laterally. And as it enters the dura, actually, let's go back for 1 second. As the carotid enters the dura, it's turning yet again. So we're coming back up distal dural ring, and then all of a sudden, we're going back on top of ourselves. So we're coming almost directly posteriorly, slightly laterally. So this is our course, and until we form the ACA and the MCA. So we're going to take this view. Let's flip it upside down and see that. So here we are. Here is the carotid, right, coming up, and forming the MCA and the ACA. Let's skip ahead. Okay, so now we're going to zoom in. So now our frontal lobes are here. Let's just orient ourselves since we've flipped again. This is inferior. We are anterior, looking posterior. And these are the frontal lobes that are being retracted superiorly. And of course, when I'm speaking about anatomical terms, I'm referring to the anatomical orientation, not our orientation. So, you know, even though this is down, this is in a superior direction that they're being pulled. So what we're looking at is we're looking down into the anterior skull base. So this is the anterior skull base. This is our pituitary gland. This is the pituitary stalk. And we can see the ICA coming up underneath that second nerve, like we saw before, coming up and terminating into the MCA and ACA. So this is our first nerve. First nerve has a very simple, straight and direct course. Goes from its origin all the way down to the cribriform plate, and that's it. Unless you have a meningioma here, not really that common to interact with. And then for the second nerve, we have the optic chiasm here. So we have the left optic nerve and the right optic nerve going into the optic canals and then into the orbit. So as we follow the ICA up, we come to that fork in the road. We have our medial road. We can either go medial or lateral. So if we go medial, we join the anterior cerebral artery, which comes pretty much on top of the chiasm or the lamina terminalis, which is that kind of clear membrane part over here posterior to the chiasm. And we come and we course upwards, and we form our A1 segment. And then we have the other side that goes lateral, which is the middle cerebral artery, and the M1 segment of the MCA. So here we have that same image, but the clivus has been removed. Same perspective. And if you think about what we're really looking at here, this is the entire so-called circle of Willis. Let's look at that 2D image again. Does it look like anything you're actually looking at here? Not really, right? So it's incredibly challenging to try and understand this, whether you're seeing it in surgery or you're seeing it on angiography or on any type of scan. It's very difficult. This is actually our vertebral artery here. This is our basilar artery. This is our carotid coming up. This is our the first segment entrance into the carotid canal. So our C2 segment coming up. And then we can see our cavernous segment after it comes immediately, it courses up, is our cavernous ICA coming up, and it's entering the dura right here. It comes up, so going underneath second nerve, coming up and giving off the MCA and the ACA. So this gives you, this gives you a slightly better idea of what we're looking at here. In terms of this image, you can see this is now in an anatomical position. Superior is up, inferior is down. Here's the brainstem, all bone removed, and here's the posterior circulation and anterior circulation, and you can see that here as well. Posterior circulation, anterior circulation. Okay, so this image may be familiar to some of you. This is a textbook presentation of a right MCA infarct, otherwise known as an ischemic stroke. And the reason you see it and it looks this way is because the MCA supplies the entire hemisphere. So when you have an infarct that's stopping blood flow, it's essentially lights out, obviously depending on where the infarct is. But if you have it low enough on the MCA, you can get a true lights out of the whole affected hemisphere. And we can see that here. And we can see let's take a look at the carotid again. As we come up, this is the carotid right at the very bottom. We're coming up into the carotid canal. That's our first genu of the C2 segment. So we're inside the petrous bone. You can even see, this is angio, right? So it's X-ray, it's fluoroscopy. You can see that this is more white than this segment because this is bone. So this is the carotid canal. It's coming in, and then it's exiting the carotid canal here. You can see it becomes darker and more clear right here. So this is the opening of the carotid canal. Foramen lacerum is right here. It's coming up. This is probably where the petrolingual ligament is. It's coming up, and then the reason it's not flat, we see too, is because remember we said that inferior bend of the cavernous segment kinks out ever so slightly laterally. That's why we see something that's thick and not, because this is an anterior-posterior perspective. So if they were perfectly in line, it would look like one single vessel to us. But because they're not perfectly aligned, you do see that anterior bend a little bit more. So it comes back up, the illustration's a little more clear on this one. So it comes back up, and then it goes through the proximal dural ring, exits the cavernous sinus, goes to the distal dural ring, enters the dura. We can see it coming up right here. Comes up, and then this is where it'll give up the ophthalmic and superior hypophyseal artery. You can see the superior hypophyseal there. This is very likely the ophthalmic artery, and it comes up, and then it ends into either the ACA going medially or the MCA going laterally. So you can see why if we have an obstruction of flow right here to our more distal segments, why we get that appearance on an ischemic stroke, because an infarct here really cuts off the whole supply. There's not a lot of contralateral flow right about here. And you can see here the M1 segment comes up right here. So M1 comes up, it gives off the lenticulostriate arteries here, and then it comes into the Sylvian fissure, and it has the Sylvian segment, the M2 segment, the M3 is the opercular segment, and then up here, M4, we have the cortical segment. So the MCA is a hugely important vessel for cortical supply. So let's take another look at the intradural segments of the carotid, but this time from a surgical perspective. This is what's known as a fronto-orbito-zygomatic approach, where you do a terional approach, you remove the roof and lateral wall of the orbit, as well as the zygoma. And once the dura is open here, the Sylvian fissure can be split, and this is what's known as a transsylvian view. So here we have a right side Sylvian fissure open. Here's our temporal lobe. Here's our frontal lobe. Here's our more distal Sylvian segment of the MCA. So MCA aneurysm is very common. You can see aneurysms in this area too. And then we have the insula. So this is opening up the full Sylvian fissure. Normally you can just open up some up here to get down here. But if we zoom in, just actually before we do, just take note of the orientation here, right? So this is the right eye, right side. This is the right eye, and this is inferior in this direction, superior, posterior down here. So we're zooming in up at the front. So this is the most anterior portion of the temporal lobe, the anterior horn. And then as we come in between here, this is where the sylvian fissure is, we can start to see the optic nerve. So let's zoom in further. Okay, so again, let's orient ourselves. So this direction, the top of the image, is anterior. The bottom of the image is, this direction is posterior. This is inferior, down, going down, and then towards us a little bit is lateral. So anterior, posterior, we're lateral, looking medial. Right, so here again, we have the carotid coming up. So this right here is that distal dural ring. So this is where the carotid enters the dura. And you can see this perspective is a true intradural perspective. We haven't opened the dura to look extradurally. We haven't gone extradural first. Here we've gone through the sylvian fissure. We've opened up the dura, the temporal lobe, gone through the sylvian fissure, and now we're intradural. So we see the carotid coming up, and the carotid is entering the dura here at the distal dural ring. This is actually the falciform ligament right here that's been cut. So and it's been cut to show the ophthalmic artery. And here we can see this is the beginning of that C6 segment. Here's the ophthalmic artery. Here's the superior hypophyseal artery, which is going to the pituitary. This is second nerve coming in, going into the optic canal. So this same exact perspective, but just a different specimen. And here, this is that C6 segment. So this is the entrance into the dura, distal dural ring, second nerve. Here's third nerve, right? This is the free edge of the tentorium. Here's third nerve going into the oculomotor triangle. So just underneath it, here we find the anterior clinoid process. So this is C6, and which goes all the way until the to the posterior communicating artery, which we find here. And the posterior communicating artery connects anterior circulation to posterior circulation, anastomosing with the posterior cerebral artery. And you can see the PCOM here gives off a lot of perforators. Then, as we continue moving along, now remember, we're intradural. So if we opened up all this dura and we looked down, we'd see the carotid coming back over itself again, right? Because remember, it's coursing posteriorly here. And it's parallel to the second nerve. And as it comes up, C7 segment, just proximal to the origin of the PCOM, all the way until it's terminated, as we go laterally into the MCA and medially into the ACA. So we've said from the beginning, C1, bifurcation to canal, no branches. C2, canal to foramen lacerum, carotid-tympanic and Vidian artery. C3, foramen lacerum to the petrolingual ligament, no branches. C4, cavernous, from petrolingual ligament to the proximal dural ring, gives off the MHT, the ILT, and McConnell's capsular arteries. C5, between the dural rings, between the proximal and distal dural rings, no branches. C6, like we saw, comes in from the distal dural ring to the posterior communicating artery, and it gives off the ophthalmic artery and the superior hypophyseal artery. C7 comes in, it gives off the posterior communicating artery, the middle cerebral artery, the anterior cerebral artery, the middle cerebral artery and the anterior cerebral artery, and as well as one other vessel. Yes. What vessel is this? Wow, people are really are overwhelmingly voting for Webner. And the reason is, actually, now that I'm looking at this, I apologize. I did not put the correct answer into the poll. So I don't want to confuse you by this. I meant to put in the anterior choroidal artery, which is what we're looking at here. So I apologize, I got this one wrong. This is the anterior choroidal artery, which supplies a number of eloquent cortical structures, as well as the choroid plexus, the lateral ventricle, hence the name choroidal. Sorry about the pull. I see my mistake now. Actually, the pull, let's try this again. The pull is asking about this artery. So yeah, most of you are on the right track that it's something in posterior circulation. So remember, this is anterior circulation coming up, and then this is going laterally, sorry, medially, and this is going laterally. And we said this is the posterior communicating artery, which comes off an anastomosis with posterior circulation, specifically the posterior cerebral artery. This from here to here is the PCOM. This is the posterior cerebral artery. So this is PCOM coming, and this is right where an anastomosis with the posterior cerebral artery. And this is the basilar artery right back here. So coming up, and it's terminating in the posterior cerebral artery. This is that anastomosis, which would make this the SCA. We also can tell that it's the SCA because it's inferior to third nerve and it's infratentorial. The PCA is supratentorial, the SCA is infratentorial. Okay, so moving a little bit medial, we can see the ICA giving off, actually here again, so we're just zoomed in, very similar perspective. Here's our carotid coming, there it is giving off the MCA, there's our ACA. So here we can see the ACA coming up, and it is, you can see right here, it's anastomosing with the anterior communicating artery. And the anterior communicating artery, the ACOM, is very tiny. And this is it. It's also a very common site for aneurysms. So on this side, this is the contralateral. This is the left carotid. Remember, we're on the right side. So this is the left carotid coming up. There's the left MCA. There's the right MCA. And we can see the right MCA coming up. Sorry, right ACA. I apologize. Right ACA coming up. There's our ACOM. Left ACA coming up, ACOM, right ACA. Right ACA, left ACA, communicating via the anterior communicating artery. Left side, right side. Right MCA, left MCA. One of the questions I always ask when I start a new course is I ask how many cranial nerves there are. Because, and most people will answer 12 or 13, depending on what you read. And I point out that no, the answer is 24, because you always have to be thinking bilaterally. Because very rarely, even if it's looking at a scan, are you going to be really just looking at one side? Or if, for example, from this perspective, we're looking at both left and right, or before you can see both third nerve, or like when we saw contralateral 6 at the beginning. So it's very important to keep in mind that it's not ever a unilateral perspective. You always have to consider that you're seeing the contralateral side. And surgically, sometimes a vascular surgeon might elect to approach an aneurysm, even contralaterally, depending on its extension. So you would go the long way. So always keep in mind, you're looking for bilaterality. So here, again, we can see a little bit more clearly, right side, left side, right ICA coming up, right MCA, right ACA coming up. There's their anterior communicating artery. Left ICA, ACA, MCA. In the middle, we have the pituitary stalk, the pituitary, the superior hypophyseal artery. We'd expect to find the ophthalmic artery right here. And these are the frontal lobes being retracted because we're a little more medial here. And coming back to this view, we can see where the ACAs go. Right, here's our carotid coming up. There's our A1. This is our anterior communicating artery, and they just go vertically up. And you don't really see the corpus callosum here, but this is it for, it forms the pericallosal arteries, and it comes all the way up and supplies the cortex up here. So let's quickly take a look at this anatomy on angio. This is the arterial phase of a left carotid angiogram. It's a lateral view, left side lateral view. So in this case, you have contrast medium injected into the left internal carotid, passing through the anterior and middle cerebral arteries up here. Let's follow it. So, and this dotted line is the base of the skull. So as we come up, this is our cervical carotid. As we turn, we enter right here the carotid canal, the petrous bone carotid canal. Inside the petrous bone, we turn. Now remember, you're looking laterally, so you have to imagine the plane you're looking in. So this is what that turn medially looks like from this perspective. And then we come in straight and we turn again. And this time we're coursing up, we're going underneath that petrolingual ligament. We're coming up, we have our cavernous segment, and we're coming up, we're entering the dura, giving off the ophthalmic artery, coming up, and then dividing into the ACA medially and the MCA laterally. Similarly, this is the arterial phase of a right side, this time right carotid angiogram. This is an anterior-posterior view. And so again, we can come up. This is anterior-posterior, so we're not seeing much of that depth. So we come up, we're coursing, that's our big course medially, that first bend in the carotid canal, coming up in the cavernous sinus. Now remember, if it were in a single plane, it would look like a single vessel. But you can see it's a little bit thicker than a vessel because that anterior bend is kinking laterally. So it comes up, we come up, we're in the dura. Now we're coming towards us with this vessel and slightly above. So the course looks smaller from an anterior-posterior view. As we come up very nicely. We give off the ACA medially and the MCA laterally, and you can follow that MCA. Now, interestingly, what you see on this side is the contralateral portions of the ACA because it's receiving perfusion via the anterior communicating artery right here. So you're seeing supplementary flow into the left ACA territory perfusion. Okay, as another brief aside, let's go back to this image. So this was the opening before we go to the transsylvian. In blue, we can see many of the superficial cortical bridging veins. And these are also very clinically important as they are the main cause of subdural hematomas. So we looked at epidural hematomas before. Here on the left, we have an axial non-contrast CT showing a large hyperdense crescent-centric hematoma extending across all the suture lines there, and that's very consistent with an acute subdural hematoma. We can also see right to left midline shift and subfalcine herniation, which we can see at that arrow there, and is generally caused by unilateral frontal, parietal, or temporal lobe disease that produces mass effect medially, pushing the ipsilateral cingulate gyrus beneath the free edge of the falx. So we can see anatomically here what this means. This is a medial perspective. This is the lateral third ventricles. The left hemisphere has been removed, and we can see this is the falx. This is the free edge of the tent. This is an opening that's been cut. So the falx separates the left and right hemispheres vertically. The tentorium separates the brainstem from the cortex. There's our carotid. And what we can see here is the cingulate gyrus would be pushed underneath the free edge of the falx. And this is subfalcine or below the falx herniation, and which is the most common cerebral herniation pattern. So to sum up anterior circulation, let's take a look at everything that we can put together from this original image. So starting at the top, we have second nerve. We can work our way down. We have second nerve, optic chiasm, second nerve going into the optic canal. Just above that, we have our A1 segments of the anterior cerebral artery that are meeting with the anterior communicating artery. They're coming down. to the carotid here. This is the carotid, internal carotid bifurcation. And this is the MCA going laterally. So the carotid's coming up, it's entering the dura through the distal dural ring. This is that clinoid space where the anterior clinoid would have been. And it's coming up through the distal dural ring, coming up and then bifurcating. And we also have the posterior communicating artery here, which is communicating with the PCA, which is our supratentorial. As you can see, here's the free edge of the tent going on top of the tent artery, whereas the SCA is going infratentorial down here near fifth nerve. So we have fifth nerve right here going up and over the petrous ridge into Meckel's cave, fanning out in the middle fossa V1, superior orbital fissure V2, foramen rotundum V3, foramen ovale. Inferior and medial to 5, we have sixth nerve going slightly upward into Dorello's canal, underneath Gruber's ligament into the cavernous sinus, on its way to the SOF, underneath V1, which is also in the cavernous sinus along with V2. Up here we have fourth nerve running with the free edge of the centurium into the cavernous sinus, into the superior orbital fissure. And here we have third nerve coming slightly downward on top of the posterior clinoid process, going into the cavernous sinus and going, into the oculomotor triangle, exiting the dura, cavernous sinus, superior orbital fissure. We also have the anterior choroidal artery up here coming off of the carotid, and you can see a little bit of choroid plexus here as well. Just quickly down here, the vertebral arteries coming into the basilar artery, and the basilar, this is the basilar tip we looked at before. And the basilar artery runs along that long axis of the clivus we've been talking about. And that's pretty much cranial nerves. We don't see one here, but one we saw before. 1, 2, 3, 4, 5, and 6, and anterior circulation. Unfortunately, I think we're out of time, so I don't know that we're going to be able to go into posterior circulation too much. We can definitely do another one of these for posterior circulation. Let's take some questions. Let's see what we have here. Which portion is the supraclinoid carotid artery? That's the ophthalmic portion, is the supraclinoid carotid. Yeah, sorry, as Ryan said, we'll put a posterior circulation lecture up soon. We can do one on the ventricles too. And actually at the end we have a survey for everybody with some questions about what other topics you'd like to see. We can put together some other lectures on different topics. I'm just reading briefly through the questions here. Do you have any recommendations for us to learn this anatomy in 3D while we're preparing for sub-I? Yeah, I will. First of all, I would recommend that you don't spend too much time reading books. I would just spend time looking at anatomical images. And unfortunately, there are not a lot of medical school-based resources for these type of things. So you really have to look in the neurosurgical literature. For cerebrovascular, even though the pictures aren't great, I really like Susan Osborne's book on diagnostic cerebral angiography. It's a great way just to learn the anatomy. She makes it really simple to understand. There's a new atlas by the late Al Roten with Maria from Albany. That's just pictures. That's what I would go. As well as for learning approaches very simply, I would read keyhole approaches in neurosurgery, ignore the approach itself, just look at the anatomy. It's a beautiful stepwise anatomical view through the different approaches. All right, well, I thank you all for coming. I appreciate it. I hope this was helpful to you, and I hope we can put on some other lectures that may be useful in simplifying some of this anatomy. I see a lot, people, like I said at the beginning, you have to spend 4 to 5 times the amount of time studying a specific region because you're learning everything separately. If you put it together, you really understand how things interact, and it cuts your studying time down significantly. And gaining that 3D perspective is difficult. If your home institution has a facility similar to ours, or a small skull-based lab where you can go and just look at some neuroanatomy or watch it, it's very useful. I really highly recommend it. Well, thank you again, and I hope to see you all at future webinars and future brain and spine group events, or actually, and hopefully soon another in-person training camp.